general antidepressants.
Problem that you present tricyclic antidepressant. It doesn't matter.
Okay, I'm going to proceed to the tricyclic. So the other is monoamine oxidase B inhibitors, especially the sertralines, which have transdermal applications, which bypasses the first bypass hepatic metabolism, and affects it doesn't affect competitively affects the myocardial. They're not going to have the monoamine oxidase A inhibition. The other most commonly not used is the third generation, which are the selective and reversible binding. The reversible binding or the third generations, which are currently being used in the European states but not available in our setup. The other cause of monoamine oxidase inhibitors are the St. John's worts and other antibiotics like linzenoids, methylene blue, and procarbamazine. When we go to the pharmacokinetics, they are rapidly absorbed from GI, absorbed from PO intake. They are highly lipophilic and they cross the brain barrier. Peak concentration reaches within 2 to 3 hours. They are highly bound to the proteins, alpha acid glycoprotein, which is responsible for the fact that we cannot eliminate enhanced elimination secondary to extracorporeal removal is not going to be possible due to the highly lipophilic nature and the fact that it's highly bound, and they are metabolized by oxidation and acetylation. For the synthesis of new enzymes for any, like especially with the first generation, new enzymes have to be synthesized, which is going to take about 2 to 3 weeks. So the patient is going to be at risk for the development of any of the complication, even after the discontinuation of the medications. But when we talk about the pathophysiology, as stated earlier, it's going to inhibit the presynaptic reuptake, so it's going to result in increased monoamine available for the stimulation. So in addition to that, there's going to be increased release of neurotransmitters in the synapse. When we talk about the possible mechanism of toxicity of monoamine oxidase inhibitors, it could be secondary to food and drug interaction, which made it unfavorable, especially since the patients have to be on restricted diets, and it could be secondary to overdose, and drug interaction is the other mechanism. The drug interaction could be pharmacokinetics, pharmacodynamic, and the idiosyncratic. The idiosyncratic could be secondary to the fact that there's going to be the other mechanism is the idiosyncratic reaction could result in serotonin syndrome, which we will discuss later on. So the clinical features, initially, like the patients are going to be delayed. The delayed in manifestation is going to be secondary to the fact there is going to be, it's going to take time for the norepinephrine and the serotonin to be accumulated in the synaptic membrane, which is going to delay the mode of manifestation. The mode of manifestation is going to be secondary to the hyperadrenergic state which the patient is going to be in, until finally, as I stated earlier, there's going to be depletion of the norepinephrine synthesis, and it's going to result in the hypoadrenergic state, which is going to finally end up in the hypotension and cardiovascular collapse. So the earliest signs are non-specific features with sinus tachycardia, hyperreflexia, drowsiness, and muscle fasciculation with generalized flushing. Moderate toxicity, the one thing we can discuss here is the ping pong gaze, which is going to be which is a unique features of the moderate toxicity and severe toxicity. It's going to be the horizontal type of the gaze movement, which is smooth and associated with actually clinical features of toxicity, and it's like 3 seconds duration. And we can look for that in our patients so that we can actually pick it. The severe toxicity in certain cases, in addition to the others, as we said, the severe toxicity, delayed slow manifestation in mono is going to result from the depletion of the norepinephrine in the synapse. So these are going to be the complications. In certain papers that they have said the pedal cerebral edema, pulmonary edema has been reported in certain cases, but it's currently not available in our country. The other is the hyperadrenergic crisis that we said earlier. The hyperadrenergic crisis is secondary to the fact that most commonly patients with previously or chronically monoamine oxidase use, those patients who are taking monoamine oxidase inhibitors, if they ingest any amount of tyramine, and thiramine injection in their diet. If they take it, they're going to have already, since enzymatic action is going to be depleted, so they're going to have this thiramine type of reaction. Most commonly, mode of presentation is going to be headache, hypertension, and fever, with potential for arrhythmias that are going to be present. The thiramine content, as we stated earlier, is going to be more prominent in processed foods and stored foods, especially the pickled and fermented medications are going to have it, especially red wine. The patients are going to present earlier on and with features of hyperadrenergic crisis, and the other peripheral signs are not going to be there. I'm going fast through this so that we can go and discuss more on the cyclic antidepressants. Serotonin syndrome, any activity which is idiosyncratic reaction and pharmacodynamic interaction immunology. And the serotonin syndrome is going to be one of the manifestations, especially if any of the monoamine oxidase inhibitors are taken with any of the serotonergic drugs that we can see, or if there's any mechanism of drugs that increases the serotonin levels, they are going to result in serotonin syndrome. We'll discuss this later. And in overdoses, they have biphasic features of manifestation. Early, it's going to be CNS hyperactivity and peripheral sympathetic activity, but later it's going to end up with cardiovascular collapse and coma. These are the mode of identification of hyperadrenergic crisis, serotonin toxicity, and monoamine oxidase overdoses. The overdoses commonly is going to present within less than 24 hours, but the hyperadrenergic crisis in patients taking previous monoamine oxidase is going to be fast within 30 to 90 minutes of ingestion of the thiramine medication. Especially this is going to be important because the treatment for hyperadrenergic crisis is going to be like conservative. The symptoms usually resolve within the next 6 hours. And the mode of treatment is not going to be, the complications are not as severe as compared to the serotonin toxicity and monoamine toxicity. The features are this. When we go to the management of any patient with any poisoning, we have to have the ABC of life has to be, initially our first priority. Otherwise, it's going to be, if we go to the history and physical examination like we were taught to do in the previous classes, it's going to result in prolonging the possible time of management. So we go to the ABC of life, supplemental oxygen, cardiac monitoring. As we said earlier, the mode of manifestation is going to be within 24 hours now for overdoses. But in certain conditions, as we said, during hyperadrenergic crisis, it could be fatal. Like the patient initially presents to us with stable features, so only to deteriorate later on. So we have to be at high attention for that. The GI decontamination could be done with activated charcoal, especially if the patient presents within 1 hour. Enhanced elimination with hemodialysis, peritoneal dialysis, hemoperfusions have no established role, and urine acidification is currently not indicated due to the fact that there is going to be AKI secondary to the precipitation of myoglobin in the tubules. The treatment of complications usually are hypertension that we stated earlier, and it could be treated with nitroprusside and phenolamines, and nitroglycerin could be used if the patient is having chest pains. And beta blockers are contraindicated due to the fact that there's going to be an opposed there's going to be an unopposed activity of the alpha, which is going to result in further hypertension. As we can see, that thiramine-related hypertension can be safely treated with lipid. Complications of hypotension, initially these patients might develop hypertension in the late phase, which is a sign of poor prognosis. If the patient fails to respond to our initial resuscitation with IV fluids, we go to the pressors. But always, for these patients, we have to be cautious not to give them indirect acting symptomatic mimetics like dopamine, since they are going to be like the end product of dopamine is going to be the release of norepinephrine. By that time, it's already depleted. If the patient is in hypotension and shock, it's like the norepinephrine is already depleted, and they're not going to have they're not going to be functional. So the treatment of complications, most commonly the arrhythmia that's going to be present is sinus tachycardia, and we're not going to treat the sinus tachycardia unless the patient is sensitive of myocardial injury and myocardial ischemia. Ventricular arrhythmias can be treated similar to the ACLS protocol, but in this case we can have lidocaine and amiodarone that could be useful in our patients. Treatment of complications, the other stated complication is the seizures. The first line of treatment for any patient who develops seizure is going to be benzodiazepines. If the seizure is still not responding with benzodiazepines, short acting active benzodiazepines like lorazepam and diazepam, we can consider phenobarbital and propofol, but we should be cautious when giving them these medications because they're going to precipitate the fact that they're going to develop hypotension, and if the patient is still seizing or having status epilepticus, general anesthesia and muscle paralysis is indicated. In these cases, we should be aware that not to use succinylcholine because it's going to, the patient is at risk for development of prolonged action, and hyperkalemia is one of the complications. And vicronium is preferred over the pancronium because the pancronium increases the heart rate. The treatment of other things is the hyperthermia. Initially, patients are going to be in hyperadrenergic state, so the hyperthermia is going to be deleterious in the fact that it's going to result in more complications like rhabdomyolysis, the DIC, that's going to be more of a problem to us. So we should complicate the management for the hyperthermia is to increase the amount of heat loss by evaporation and conduction. So the fans and we have to expose our patients and we have to do cold compression. But the ice bath immersion could be indicated for patients with the rectal temperature. There's only one page that says bad ice bath immersion for rectal temperature greater than 41.1. Rigidity and altered mental status, that's unresponsive to the cold conduction and evaporation response minor villanophone. We should immerse our patients in ice bath so that we will be able to cool the temperature. The other line is the benzodiazepines if we're going to treat them. It's going to relax their muscles and sedate them, so they're not going to have the hyperactivity of the muscles, which is going to result in further hyperthermia and rhabdomyolysis. And if it's resistant treatment, muscle paralysis should be considered. Medications that are not safe to be considered are these drugs, but we should be aware not to give our patients any medication that, if they present to the emergency, we should be vigilant enough not to give them any medications that's going to increase the serotonergic activity, like the ones I have stated above. The below the meperidine, initially meperidine was found, it increases the serotonin concentration and it's going to have serotonin toxicity if we actually give it to a patient who is taking oxidase inhibitors. Dextromethorphan, tramadol, and benzenoid. Benzenoid is monoamine oxidase inhibitor by itself, and addition of this is going to result in more toxicity. The others, as we stated earlier, monoamine oxidase inhibitors, especially the non-selective or the first generation, is going to be non-competitive and irreversible. So we should advise our patients, even after discontinuation of the treatment, that they should avoid certain sympathomimetic drugs so that they will not have any of the other complications that are stated above. So we go to second antidepressant. Anybody who has had any experience in finding patients with tricyclic antidepressants or cyclic antidepressants in general?
Yes.
What did your patient take?
Amitriptyline.
Amitriptyline. How much?
10 tablets. 200.
When we come to the cyclic, so what was done for this patient initially?
Initially, she was resuscitated with fluid. She was initially hypotensive. Later, we give her sodium bicarbonate.
What was the indication to give this patient sodium bicarbonate?
Hypotension and change in meditation.
So after
ECG, we don't have ECG finding, but she was change in meditation and hypotension.
So did the patient improve with the sodium bicarbonate that was administered to her? What was the improvement? What did we follow?
The blood pressure and the mental status change.
So this is one of the examples. Personally, I didn't have any experience in dealing with patients who had any antidepressant toxicity. But when we go to the brief history, initially in the 1950s in Nepal, that was as a hypnotic agents that were initially produced in Tanzania, but progressively through the years, they discovered that it has significant cardiovascular and CNS toxicities, which currently are favoring alcohol. But still, as a country that is developing, we usually have mostly in the with the cyclic antidepressants currently still in use in our country, especially as a first line of currently in the other countries, especially in America, it's not indicated as a first line treatment for adults, but in pediatric patients, especially the ones with attention deficit disorder and emeregency, are still using it. So we should be able to know the possible manifestations of this toxicity so that we can actually pick our patients earlier. We can divide them tricyclic the non-cyclic clinical fluctuation, or we can just divide them in tertiary amines and secondary amines. When we say tertiary amines, especially with the ones that are available in our country, amitriptyline, imipramine, and clomipramine natural, they are available in our country in governmental hospitals as well as in private sector. The importance of the tertiary amines is they are usually metabolized to active metabolites, which is going to prolong the duration of action and the production of active metabolites, duration of action, and the elimination half-life in each number. It's going to increase the elimination half-life. In addition to that, it's going to the area of the area that they're going to focus on is completely different. Actually, completely similar. It's like in a way it's different at therapeutic doses. But when with supratherapeutic overdose, the selectivity is lost. Amitriptyline is metabolized to nortriptyline and imipramine to desipramine during the process of demethylation that is going to happen in the liver. And at therapeutic doses, they inhibit the reuptake of serotonin and or norepinephrine. So, briefly from all of this, we're going to be interested in the fact that they're going to have rapid absorption. Like I read one paper that said we can have, due to the fact that they're going to have a prolonged stay in the GI, due to the fact that there's going to be antimuscarinic activity and paralytic illness, we can consider gastric lavage even after a prolonged period of time. But currently, that's still not accepted, but still there are certain books that suggest the fact that we can actually do gastric lavage after a prolonged time, but they have excellent and rapid absorption after PO intake. They are highly lipophilic, and their peak concentration reaches about 2 to 8 hours after ingestion, but the large volume. They have large volume of distribution from 10 to 15 ml, 15 liter per kg, and they are weekly basic. This is very important initially, since as you said earlier, they treated the patient with sodium bicarbonate. The rationale behind treating the patient with sodium bicarbonate is that the fact that they're weekly basic. The adverse effects or the clinical manifestation we're seeing is due to the fact that there's going to be ionized amount of this drug that is present in the blood, which is there to inhibit the sodium channel blockers. So the sodium channel which block emeregency is during ionization. So the goal in this patient is going to be serum alkalization and decreasing the sodium concentration within the plasma, so that there will be dissociated adrenaline, and the tricyclic antidepressants or the antidepressant is going to move away from the lipophilic center, from the hydrophilic center into the lipophilic center. So that's one of the things that we have to know, like serum alkalization, weekly basic matches. As the acidity increases, they're going to be more unionized, and acidity decreases, they're going to be ionized and more toxic to our patients, especially in patients acidity if they're going to have hypoxia and other concomitant drug intake, or if the patient is going to have depressed respiratory level, acidity level might increase, which is going to potentiate the effect of this medications. This cyclic antidepressants, not only in overdose, not only do they manifest in overdose patients, but within the therapeutic range, they can have the clinical manifestations. Especially this is important if we're starting the patients with high dose cyclic antidepressants, previously naive low monoid. Have to be when starting patients on cyclic antidepressants, progressively escalating their denominator, because the patients have to be acclimated to the adverse reactions, and they're going to manifest with the toxicity features if we actually start them rapidly on high dose. So the other, these are some of the features that they're going to have, like if they're going to develop toxicity at therapeutic doses. So if the patient is having like slow metabolism, especially like eliminating mineral element, they're going to have hepatic elimination. Hepatic elimination is called as there are slow metabolizers actually. The fact that the enzyme is going to be occupied. So like slowly metabolize marijuana, they are at risk for developing serotonin syndrome or any of the other complications that we see with cyclic antidepressant easily at a normal dose. So these are some of the manifestations at therapeutic dose. These are some of the drugs that we have. Amitriptyline daily dose of 750, maximum daily recommendation of 300 ml. Amoxicillin, it's unique in this class because amoxicillin, like similar to the other drugs, similar to the others, it's not like structurally similar, it's going to have the same adverse effects. It's going to result in the inhibition of the norepinephrine channels and weakly, it's going to have a weak effect on the sodium channel. So the toxicity with amoxicillin is not going to result in similar manifestations that we see with the typical tricyclic antidepressants of avoiding the QRS complex or the QT prolongation. Clomipramine and desferamine are the amitriptyline has a byproduct which is going to increase the toxic life and the toxicity and the elimination period action increase the matter of. So these are some of the mechanisms that the pharmacologic activate the mechanism of action which is responsible for the toxicity. The important there is the fact that we use this drug for the depressed patients came from the hypothesis of monoamine, it's found to uplift the mood, so that's why they're going along this. But the exact cause of that depression is not known, so that's why we're going the certain neurotransmitters are being focused. So these are some of the adverse effects that are going to be secondary to the non-beneficial parts of this manifestation. The pharmacologic action stated earlier is going to be secondary to the fact that it's going to inhibit the monoamine uptake and the postsynaptic inhibition of the serotonin. The other effects are not important pharmacologically, but they are important toxicologically, especially I stated it in the decreasing order of prevalence. And the first thing is antagonization of the histamine receptor, especially in the CNS, in which the patient is going to manifest with sedation. The causes of sedation could be multiple and multifactorial. The other is antagonism of the muscarinic receptors. We have listed the common complications. The antagonism of the it competitively inhibits the acetylcholine the muscarinic receptors, which results in the manifestation of central and peripheral. They're going to have the toxidrome of antimuscarinic toxicity, so we should be on the lookout. The features of antimuscarinic property are going to be the things we have to look for in our patients if we're suspecting this. They're going to have the agitation, the sameness manifestation could range from agitation, confusion, delirium, and multiple, but they're going to have they might have the dilated pupil. The pupil might be normal size, as I will discuss it later. The patient are going to be hyperthermic due to the fact hypertensive, and there's going to be decreased oral and bronchial secretion. They're going to have illness, but the fact that the patient having normal bowel sound is not going to exclude it. They are resistant to the antimuscarinic property. So if a patient has normal active bowel sound, that does not mean the patient is not having cyclic antidepressant toxicity. There's going to be increased muscle tone and urinary retention. The other is antagonism of the alpha-1 adrenergic receptors. They are more preferentially inhibit the alpha-1 rather than the alpha-2, which is going to result in the features of sedation. As I said earlier, the sedation could be secondary to the fact there is some H1 receptor blockade, or it could be secondary to the antimuscarinic property or alpha-1 adrenergic property, and they're going to have orthostatic hypotension with reflex tachycardia and pupillary constriction. The antimuscarinic property shows us the toxicity, but the patients with cyclic antidepressant toxicity might have mid-sized, normal, or dilated pupils. This is going to be like the offsetting parting donut. They are not going to have the typical features of antimuscarinic property, but they're going to have some part of it, which is going to be beneficial for us to pick on, but the fact that like madrasicin normal does not mean the patient doesn't have any, does not have tricyclic antidepressant toxicity يلاቸው ማለት አይደለም. The important mechanism, like the inhibition of, antagonism of the amine reuptake is one of the things that is going to be pharmacologically beneficial. The most important thing when we're discussing about cyclic antidepressants is the fact that there's going to be sodium channel blockade. What do you mean? Like, what do you think I mean when I say like sodium channel blockade syndrome? What's the function of sodium channels in our heart, in the myocardium or in the heart structures? What's the function of it? Sodium channels. What's the function of sodium channels and how do they matter in the cardiac contractility and conduction? Anyone?
Sodium influx depolarization.
Where? Location. Sodium influx in which part? In which part? In the SA node, in the AV node, or the fast responding tissues like the His-Purkinje system or the myocardium, the ventricular myocardium, where the fast influx of sodium, important immuno is where? Anybody? The first entry of sodium channels is going to be more important in the not in the AV node. In the AV and the SA node, the entry of calcium is more important for the depolarization. But in the other high sensitive and the fast responding tissues, the phase 0 is going to be due to the fact that there's going to be rapid entry of sodium into the cells, rapidly depolarizing it. And with the entry of sodium into the cell, there's going to be entry of calcium in the later phase, which is going to be responsible for the myocardial contractility. So if there is any inhibition, we see here the cyclic antidepressants inhibit the entry of sodium into the intracellular, prolonging depolarization of non-quadrilateral fluid. We're going to see ECG manifestation of QRS duration is going to be prolonged. That's going to affect the total period of depolarization and repolarization. And indirectly, due to the fact that the sodium is going to be prolonged in scalendrus, the calcium is going to be prolonged, it's going to affect our cardiac contractility. This is one of the mechanisms. As stated earlier, he said we gave our sodium bicarbonate, this is the mechanism. And again, we're alkalizing it, we're alkalizing the blood, so we're going to increase the unionized part of the drug. In addition to that, we're increasing the cellular concentration of the sodium, which is responsible for the therapeutic effect, and increasing the entry of sodium into the cell so that we will have the therapeutic benefit. And this is how the action potential is generated, and in the SA node and the AV node, the entry of calcium is going to be responsible, and in the atrium, in the bundle of this, and we know in the myocardial contractility, in the ventricular myocardium, the fast acting sodium channels are going to be responsible for it. This is one of the one of the things that we have to be aware of, since we're saying it blocks the phase 0 of depolarization of the heart. We're going to anticipate widening of the QRS, and there's going to be QT prolongation due to the fact that there's going to be increased time to depolarize. And the other proposed mechanism for the development toxicity is the potassium channel antagonism. It's not sure that, sorry, I forgot. The other thing that we see with the cyclic antidepressants is the block of the right bundle branch. The right bundle branch has a relatively longer refractory period rather than the left bundle branch in any other part of the heart. So it's going to be one of the things that is going to be affecting the depolarization, and one of the features we're going to see in the ECG manifestation. The block of the right bundle branch is going to result in features of right bundle branch block, incomplete block, which is going to increase the terminal 40 milliseconds of the QRS and RBB pattern. I'll show you the picture. And what do you see on this ECG? we said calcium channel, the cyclic antidepressants depress the fast-acting sodium channel, and it's going to result in RBB pattern with right axis deviation. So what do you see on this ECG?
Right axis deviation. Another there is tone arrow. Slightly wide.
Why didn't? Okay. Anything else? Anything else? Says it there is right axis deviation. Deep phase wave वाला लेला. ST-wave inversion that are non-specific are still present in B1. This is for a patient that was taking cyclic antidepressants with severe toxicity. How about on this ECG? What do you see? Is it different from the previous one, and how is it different if so?
Wide.
Slightly wider. Okay, Leila. The QRS is wider. Look at least AVL and AVL line natural. What do you see the S wave opportunity natural? S wave to the R wave abnormalities, and AVR line, how's the AVR? How's the R wave? Down sloping natural the S wave and in the AVL and AVR line, R wave is prominently tall. So this is a sign of severe toxicity. Okay. The other is the potassium channel blockade. The potassium channel blockade prominent. It prolongs the QT symptom. Widening of the QRS complex, third S wave in the AVN ladder, and non-specific ST segments depressions, and third in lead 2 and lead 5. And lead 6, at least 6. Yeah, QT1 is like calculated. It's wild complex tachycardia is one of it. QT prolongation is going to be very good.
Why is
We're like properly intelligent. No.
It should be correct.
Mostly corrected, sir. Corrected has to be corrected and will not.
how do you calculate at least grossly?
How? More than that.
V1, V2,
This is the potassium channel antagonism is most commonly for chronic toxicity in patients who are taking chronic therapy of cyclic antidepressants. And this is due to the prevention of the efflux of potassium is going to affect repolarization. But the other thing is the prolongation of the QT, it could be secondary to the prolonged repolarization and depolarization rather than the prolonged repolarization. And the fact that the prolonged QT is predisposing the patients to torsatic pointis, and which is more common with patients with chronic tricyclic antidepressants intake. And the other is the DAWA-A receptor antagonism, which is going to result in the seizures in 10% of the population. The cause of the seizures are multiple. In addition to the GABA-A blockade, we're going to have the central muscarinic activity, which is going to result in sedation. And like the central manifestations, which range from sedation, agitation to seizure. It could be the effect of biomice, the antihistaminic effect, or the blockade of the neuronal sodium channels. The toxicity, most commonly, it's wide variety neuroretinal with the available preparation. Most commonly with the cyclic antidepressant, therapeutic dose is between 1 to 5 milligrams per kg per day. And the life-threatening symptoms are associated with ingestion of more than 10 milligram per kg, and fatality dose have been associated with intake of 1 gram, especially in adults. Certain symptoms, mild to moderate symptoms, could be seen in patients, adults dying who have taken about 2.5 milligram per kg. 2.5 milligram per kg with ingestion, we might have mild to moderate symptoms. Especially kids, children are pediatric age are more sensitive to the antimuscarinic effects, and they're going to develop toxicity at a lower dose. In addition to that, the patients at higher risk of toxicity are those patients that are taking the cardiotoxic drugs, sedative hypnotic medications, geriatric patients, due to the fact that hepatic metabolism is going to be reduced, and other patients with underlying cardiac or neurologic manifestations. Chronic toxicity is not most important, and it could be with confusion and urinary retention. Based on to diagnose toxicity, we're going to use the history of exposure, the clinical symptomatology, the ECG findings, and the positive urine screening. And the positive urine screening is the qualitative and the quantitative assays are not going to be helpful in the management of our patients, but rather for screening. With the qualitative one, they're going to be increased false positivity associated with congestion of other drugs, especially carbamazepine. And the quantitative amount is not going to be beneficial for the acute toxicity, since the clinical toxicity is not associated with the serum level. It's going to be for the long-term management, for the long-term follow-up of our patient and their drug level, so that we will not develop toxicity. The other is history of exposure, which is very important. How much, when, where, and what time did they take it is very important, since the patient is going to rapidly deteriorate. Initially, patients with cyclical antidepressants, they are going to be like healthy looking, they are going to rapidly deteriorate if we do not know like how to anticipate like the complications we should anticipate and how to monitor them. If we don't know them properly, they're going to rapidly deteriorate and we're going to lose the patients. And the clinical symptomatology that we have discussed earlier is going to be a very important part of our management. Major toxicity criteria are the parts of the complications, that adverse reactions that we have stated earlier. So any patient with for any patient who comes to the ED with toxicity or ingestion of unknown substance, we should follow the ABC of life and then identify the typical drug that is ingested, and know if there's co-administration and treat according to that. So these are some of the features. The clinical manifestation of acute overdoses. The clinical features might be mild to moderate to severe with cardiotoxic and central nervous system collapse. As I said earlier, the antimuscarinic properties are the ones that are going to hit us with toxicology. Mostly patients with cardiovascular toxicity present with sinus tachycardia in the rate of 120 to 180. Hypotension is one of the things we have to be conscious of. We have to be aware of. If the patient is failing to respond to IV fluids, we should consider refractory hypotension, which is the most important cause of death in patients with cyclic antidepressant toxicity. And it's not just one factor, it's multiple factors are responsible for the development of this hypotension. VTAC and ventricular tachycardia and ventricular fibrillations are common in severe poisoning patients. The other is the ECG features that we're going to see, and the fact that the Mugara syndrome features are going to be present in 3 to 40% of the patients. With CNS toxicity, the most important thing is altered mental status and seizures. The altered mental status could be decrease in the level of consciousness, agitation, delirium, or hallucinations. The other is the antimuscarinic property. So all in all, it's not just one manifestation that we're going to have, but rather a constellation of signs and symptoms that are going to lead us to the diagnosis. When we consider patients that have come to the ED, we should immediately, any patient that coming to the ED should have the basic ABC of life and should be monitored on ECG. We asked them earlier on if there is any ECG findings. So the ECG finding is going to help us to actually manage the patient, prognosticate, and actually anticipate the complications that are going to be there. Prolongation of the QRS duration is one of the most important things. If the QRS duration is greater than 100 milliseconds, in general, they're going to have increased risk of seizure and ventricular tachycardia. Especially if it's greater than 160, 50% of our patients would have ventricular tachycardia and the other complications that we're going to see. Abnormal morphology of the QRS complex that we saw earlier on. Deep and slurred S waves in the AaBET and D1 are going to be the features. Abnormal size and ratio of the R wave to the S wave in APR is going to be one of the most important things. Remember the ECG that we saw earlier on? The number of R waves especially is supposed to be like isologic or less than 1, but if it's going to be greater than 3, it's going to be suggestive of toxicity. And the R to S ratio is going to be greater than 7. Other features, similar to the other findings that we're going to have, the other features of toxicity that we have. So the patient might have a prolongation of the PR interval, the QR interval, variable degrees of heavy block and conduction blocks are going to be there. So this is the terminal wave terminal, the last 40 milliseconds of the AVR diameter. The duration is supposed to be at least 1 millimeter. If it's greater than 3, it's highly suggestive of the toxicity, so we should put our patients on cardiac monitor and follow the QRS complex. The QRS complex and the AVR. Cardiac monitoring is essential because it's a stage earlier is going to not only help us in the management and follow up, but it's going to help us prognosticate the outcome. So, management, always, it's for us it's the ABC. And if the patient is going to have the GCS less than 8, is going to, like low GCS is going to tell us there is significant toxicity. So we might need to intubate the patient for airway protection as well as failure to oxygenate might be there. So depressed GCS is one of the indications for airway protection with intubation. Early initiation of mechanical ventilator could be one of the indications. In addition to that, the fact that the hypoxia is going to worsen, the acidosis should be considered, and especially in patients who are like having deep level breathing, we should consider early intubation and mechanical ventilation. With the circulation, we said earlier on, hypotension might be one of the prominent features of this. So if a patient is hypotensive, initially for all, we have secured initially IV line, and the patient is going to be resuscitated with crystalloids. And if the patient remains hypotensive, we have vasopressors, especially norepinephrine and phenylephrine could be used. The other thing, the most important thing is we have to see the conduction disturbance. Like management touch and affect medical, like we are going to follow the QRS complex. So when we're administering the sodium bicarbonate, we have to see a certain change in the QRS complex. By administering the QRS complex, if there is no response, with 1 to 2 milliequivalent per kg, we're going to have, if there's no response, repeat in nasal coagulant. If there is response, we're going to continue with maintenance production interval. We'll continue with the maintenance route of sodium bicarbonate. And the conduction disturbance and the indications for initiation of sodium bicarbonate is the fact that they're going to have wide QRS complex, altered mental status, and hemodynamic unstable or hypotensive patients are the indications for starting on bicarbonate. So these are the things we have to follow. The other is GI decontamination. If they like present earlier on pneumonia, if they're present earlier on, we can consider activated charcoal. The treatment of hypotension and arrhythmias are going to be the sodium bicarbonate that we have discussed. And hypokalemia might be one of the things. With serum alkalization, we might be leading our patients to fluid overload and hypokalemia and other serum electrolyte abnormalities, so we should be able to monitor that and follow our patients. And if the patient is agitated or seizing, still the benzodiazepines are the first line, and phenytoin is contraindicated for patients with drug-induced seizure, so we should be aware that we should not be giving our patients any phenytoin, and others, the phenobarbital could be used. Still caution, be cautious that we are not inducing hypotension, and these are the common manifestations. I will discuss on the complications that are refractory to the initial treatment. We said the initial mode of treatment for any arrhythmias, hypotension, and the conduction disturbance is going to be the sodium bicarbonate. But in certain cases, there have been shown, like if the patient is unresponsive to this medications, what do we do? So we have to be like second line. Like we said, fluid resuscitation, unresponsive. If we start from pressors, if the patient is still unresponsive to that, there are certain indications where we can start. But the inotropes or the pressors are going to be started at a low dose and progressively escalate. And if the patient is still unresponsive to that, and we can start them on 3% hypertonic saline. Good. The indication to start 3% hypertonic saline is like the patient has failed to respond to IV fluid resuscitation, and there's no narrowing of the QRS complex. There's no resolution of the hypotension, so we might consider hypertonic saline. And certain patients, in certain research papers, they have shown it to be more beneficial than sodium bicarbonate, but still, like wide and broad in evidence that we should use it more than sodium bicarbonate. No argument or groups of researchers are there. The other is refractory arrhythmias. The refractory arrhythmias, when we're saying refractory arrhythmias, this means the administration of the sodium bicarbonate at the usual dose. The patient is not responding with the narrowing of the QRS complex for this patient, and the hypotension is persistent, so we can consider magnesium sulfate administration. The other is lidocaine. We can administer lidocaine similar to that. Phenytoin has been shown to be beneficial. The administration of phenytoin has been shown to be beneficial in certain cases, but still not recommended as one of the, even like the third line of treatment is not one of the indications. At any cost, for any patient with suspected of cyclic antidepressant toxicity, we should avoid the class 1 and class 1A and 1C drugs, and 1A and 1C, and the use of amiodarone class 3 with the QTC prolongation should be used with caution. Even if they develop ventricular tachycardia, they should, like, we should go for the ACLS manifestation, and the ACLS manifestation, they might be refractory, but still the mode of management should be focusing on the magnesium and lidocaine. The other, if the patient is having severe type of hemodynamic instability and unresponsive and impeding arrest, the other proposed mechanism is lipid emulsion, which has been proposed for the elimination of highly lipophilic drugs, which are most of our antidepressants are highly lipophilic, so we can consider lipid emulsion for the mode of treatment, but still currently not widely used, and we can use this like the amount of 1 to 1.5 ml per kg over 24 hours. If there is no repeat, if there is no response, or if the patient develops cardiac arrest, we can repeat it, and we can go for the infusion later on. There are certain drugs that are still contraindicated to be used. Like earlier known, the antimuscarinic properties are the ones that are going to predominate. So any drugs that are going to affect this antimuscarinic property should not be used, like physiostigmine. Like patients might disorder despite that. So like the features of antimuscarinic toxicity should be like supportive management is going to be sufficient enough, and the administration of physiostigmine is going to be contraindicated, and like Ayalew mentioned, the class 1A and 1C drugs are still contraindicated, and unless no other evidence of no other possibility, you still should avoid the class C drugs. And we should follow our patients, not only due to the cardiac complication, due to the blockage of the sodium channels and the antimuscarinic property. All along, the patient might have secondary complications associated with the cyclic antidepressant toxicity, which we will have to like follow at the same time, like manage non-ergo. We have to anticipate the secondary complications and actually investigate them if they have developed it ahead of time, so that it would affect our management. And I'm going to go to the serotonergic antidepressants. Any questions? Anything you would like to ask?
like over stage, patient with 250 and 80 with hypertension. So what things should we do? You have such cases.
We have-
Not depend, but severe deficiency. It's one question. Other is in magnesium sulfate. So is there any evidence of support for any white pairs complex except cystose and sequence or fluoridation from magnesium sulfate? Or is only for that purpose? And the other is doing sodium bicarbonate for white complex only. So this is asymptomatic. Is white complex just a direct indication for sodium bicarbonate?
I will start with this question. The last, well, I will start from the last and go on to the first. What the indications for initiation of sodium bicarbonate is the white complex hypertrophy, hypotension, and the bradyarrhythmias that the patient might benefit. So might manifest. So this is one of the indications that we have to start our patients. Other mental status is one of the other indications. So rather than if the patient mostly with this cyclic antidepressant, they're going to have a wider complex apart from amoxicillin that I stated earlier that we might not have a widely. So we should have any patients that come with these features of toxicity, other mental status, including seizures, should be started on the sodium bicarbonate due to the fact that this effect is going to be multifactorial ionization of the serum, and it's going to have increase the sodium concentration in the cells. So this is going to be the beneficial components of it. Well, the other question was the use of magnesium sulfate. The use of magnesium sulfate has been debated in many.
Just even though the patient is not in shock with patients having physical poisoning, do you keep sodium bicarbonate? Yes. Why do you call this?
The indication.
More than 100.
More than 100 colon, the risk of ventricular, the risk of tachyarrhythmias is going to be increased depending on the duration. 26% is going to have ventricular tachyarrhythmias with progressive widening of the PORS complex, and the duration greater than 100 milliseconds is an indication to give them sodium bicarbonate. And we're going to follow that if there's going to be narrowing with progressive administration of the sodium bicarbonate that we are going to administer.
Even today, sodium bicarbonate, even the only indication is QRS. Even multiple white QRS, multiple internet, even change in meditation, hypotension, criteria. Mostly research የተሰራው ላይ QRS initially why ያላቸው they will develop seizure and they will develop pulmonary edema እና እንደውም early ከመጣ we should give sodium bicarbonate. They are not symptomatic but QRS.
The most important two indications to give sodium bicarbonate, one QRS, the other refractory. Otherwise, changing meditation is not strong.
Sometimes the level of the QRS is widening and determine the prognosis and the complication.
Yes.
There are things to say not just 100, some say 110, 120. Yes. So it depends on the severity. The more the widen, the more severe, the more complicated. So most doesn't recommend more than 100. We need to be careful if it's more than 100, but if it is really more than 120, we need to treat, even though they are not active. Magnesium.
The use of magnesium, in addition to, it's going to increase the serum alkalization level, but the other indication I have not come across the indication. If it's widened and not responsive to the administration of sodium bicarbonate is one of the indications, serum alkalization, and like one that suggests that, the otherwise the exact pathology, physiology. What was the first question?
The issue of magnesium is, I don't know why we make it the first time. It's not the first time.
It's
But you're right.
for refractory. For refractory, for refractory arrhythmias, refractory cone, if it's not unresponsive to the first line. The first line is going to be sodium bicarbonate. If the patient is going to be unresponsive to that, and
What anti-arrhythmic?
we can go for like the lidocaine and the ones I stated earlier.
Especially for QT prolongation.
Mainly magnesium prolongation arrhythmia is not the arrhythmia related. What is arrhythmia? So if they are community-wide ignorantial, then the complicated, then you can like cancer. But the trial is for lidocaine and phenytoin. You can try lidocaine. First trial, lidocaine and phenytoin. Then you can try phenytoin. Otherwise, you sodium bicarbonate.
Do you recommend anything for the patients having to say?
It's not recommended. It's like even the last evolution measure recommended my doctor, so one of the recommendations.
You don't have any choice. Because why phenytoin has does phenytoin have anti?
One week and last recommendation.
The contraindication is 1A and other class 4.
Class 1, class 2.
Why do you think the patient is a normal maybe start natural?
The other dose, we have the pharmacodynamic, the 9 patient immune administration of slightly higher hormone, we can have the toxic effects. If the adverse effect nature is going to be more prominent at a higher dose rather than a smaller dose. The other is the type of hepatic metabolism that the patient might have. And in addition to that, they might have drug-drug interaction and elimination could be affected. And like multiple factors, the circumstantial factors are one of the things, even at therapeutic dose, manifest allergic የሚችሉት እነዚህ ናቸው። The pharmacodynamic interaction, the pharmacodynamic interaction, the circulatory syndrome, for administration of other drugs, and the naive patients are at risk for complications. One of the things we have to know is that we cannot treat the hyperthermia associated with these suddenly antidepressants with paracetamol. Rather, we can go for other mechanism of treatment. The generation of the fever could be controlled, and as I said earlier, we can increase the evaporation, but rather antibiotics like acetaminophen are not going to be effective. So this is not one of the things we have to do. The other medications, with general anesthetic, muscle relaxant, and sedative agent, which will antibiotics are not going to be effective. And what was the first one? Sorry. Dialysis is not going to be effective in these patients because they are going to have highly lipophilic, and they are going to be mostly, other than the plasma, they are going to be found in tissues, so that is going to be beneficial.
High volume distribution and
Protein binding could be affected by the acidity, but we can have like highly lipophilic nature. That's going to be like immediately after absorption, after intake, is going to go to the other tissues. The tissue concentration of tissue to the plasma concentration is going to be 10 to 1, more than that, 10 to 100 times the number is not going to be effective. Blood interferon is not going to touch the tissues.
Second line
with the IV and they will be
PowerPoint line.
Oh, sorry.
When we say refractory and how we administer sodium bicarbonate?
Well, we say refractory arrhythmia, especially if there is no the QRS complex is not going to be narrowing despite the administration of one of sodium bicarbonate. It's still wide component. We're not going to when we're narrowing or but when we're administering sodium bicarbonate, we have to anticipate there is other component going to be associated other cellular despite administration by We can give them as an IV push until initial IV bolus we can administer it, and then progressively as an infusion after 25%
So first we give one prefibulatory for bonus. So after 5 minutes we assess the ECG. If there is no any change in the ECG, we should reduce the bonus. If the narrowing, we should start with the fusion. So bonus is not a single bonus. Every 5 minutes we assess the ECG. If there is no narrowing, we should reduce the bonus.
infusion
Infusion response for so single bonus level, second bonus.
there is one set that
ይሄን ኬት ነው 1 ሚሊግራም per kg ነው how much is
Then after 5 minutes still wait for respond with infusion
there was another, despite the administration, with multiple bolus and putting them on infusion, and the patient is still not having the narrowing. That's one of the indications, and we look at clearly like the amount of boluses that we give is not very well, like multiple bolus and still putting them on by perfusion if there is still narrowing, you can consider the others. So the amount of boluses that
especially now say just giving 1 to 2 milligram it's difficult one is the tension
So the follow narrow page. So our target so we make our so the after border so the page no further so we make our so we can go to video. But you can jump program. My is the spiritual program. Among the spiritual
class 1A, 1B, 1C power depending on the potency of the sodium. Usually class 1B they are less potent or less sodium.
So look, this place is say first this place was 40 minutes then you can this up as the matter is there gas we take 6 minutes for the sodium I will
my person is good time to review
half strength contains glucose, so that we
እዚህ ጋር በጣም ፎከስ ማለት ያለባቸው ስታንዳርድ ማኔጅመንት አሁን ስፔሻሊ ነው ሴት ቤት ያለች ነው አንደኛ ፔጅ you don't determine writing that you don't determine the potassium ቤት ሳይድ determine management so this level of sodium bicarbonate it's difficult
what you can do is like 1 milligram per kg in 1 liter below 250 ml per hour or
when dopamine deficiency high, how to give dopamine bicycle for
without skills, removal of norepinephrine, and it's not going to have the ECG features, so cautiously, and still the toxicity is secondary to the metabolites and the other complications for emergency, so the piece of antidepressant is not then we should be aware that there are increased risk procedure and with